So, good evening, everyone, and a warm welcome to all participants, either on site or online. My name is Tobias Koenig from Hanover, Germany, and with me is Felix Mahfoud, who is the moderator of this exciting session. I'd like to introduce our experts. Suzanne Waha from Munich in Germany, Andreas Schäfer from Hanover, Germany, and we're happy to have Gregg from New York, US, per remote with us. So we're talking today about an exciting issue, special therapy beyond primary PCI in STEMI patients, and we all know the burden of heart failure in patients with ST elevation myocardial infarction is high, and the prognosis of those patients is poor. And in recent years, we've seen several therapies that have failed to demonstrate impact or improvement of outcome. And there is a promising therapy that we want to introduce today. It's kind of a relatively new kid on the block, and it's called SuperSaturated Oxygen Therapy. So the chat master is Dirk Treutsch from Zoll, and we encourage you to ask questions either via the microphone here in from the audience or in the chat via the app. And so I'd like to hand over to Felix Mahfoud to kick off this hopefully exciting session.
Thank you very much and good evening. This is intended to be an interactive session, so please feel free to ask as many questions as you want. Use the faculty, the audience here, so that we can address all the open points for this new and novel technology that becomes available in many geographies now. My talk is not a formal talk, it's more to put it into perspective what we're going to discuss today, and there's absolutely no need, particularly in this audience, to highlight the advances that we made in interventional cardiology, particularly primary PCI that significantly reduced mortality of patients with STEMI. But what this slide also shows, and Tobias Koenig mentioned it already, we are reaching a kind of plateau. So despite progress in various specialities and also including new devices that become available, there is less improvement of outcome in recent years. This is an example out of the US where you can see that despite improvements in PCI, for instance, with reduced or to balloon times, new stent technologies, and I think of great help in these patients is a tailored antiplatelet therapy regimen. We have stagnated STEMI outcomes as shown here with the in-hospital mortality and in patients with acute myocardial infarction that reaches 15%. What about heart failure in STEMI patients? And this is a matched population, anterior STEMI patients with no cardiogenic shock, no renal failure, more than 2,500 patients per year. And there were no statistically significant differences between outcomes compared almost 2 decades ago, 2005, as compared with recent years, such as 2018. So PCI is, of course, standard of care, has reduced significantly morbidity and mortality of patients with STEMI, but outcomes of death and heart failure remain stable since 2005 almost. What about heart failure in acute myocardial infarction post-primary PCI? This is a very recent publication, a couple of weeks old, where the colleagues looked into a large database out of the US, and after myocardial infarction, almost every 5th patient develops a heart failure within 5 years, and particularly CKD and recurrent myocardial infarctions are strong predictors for the development of heart failure post-myocardial infarction. Of course, it is of utmost importance to open the epicardial artery, but we're gaining more and more insights into downstream microvasculature and into the importance of microvascular patency. And this session here is also around microvascular patency and a microvascular obstruction, which has indeed been correlated with poor outcomes. So this is, again, a small background information, I think, to set the stage, to put this on center stage, indeed, that there is a huge unmet need which should indeed improve outcomes in patients with acute myocardial infarction. Thank you very much for listening.
Okay, so next part is a case presentation by Andreas Schäfer from Hanover, Germany.
Yeah, dear colleagues, dear Tobias, dear Felix, the question was, is PCI enough in STEMI? And this will be a rather short introduction. My conflict of interest is that I'm using different devices that are intended to be used to reduce infarct size following acute AMI. And the typical scenario that I want to bring into this room is an acute STEMI case. It's a 48-year-old female having symptom onset at 11 o'clock in the morning, calling the emergency medical system several hours later, actually. Her cardiovascular risk profile comprises arterial hypertension, hypercholesterolemia, and smoking, so nothing special. She complained about typical angina. The paramedics and the emergency physician wrote a 12-channel ECG that depicts ST segment elevation in the anterior leads, and the patient was put on the STEMI fast track and arrived at the cath lab at 4:30 in the afternoon. Now, we did what we normally do. We do a coronary angio, and you see that all three coronaries are somehow affected by atherosclerosis, but predominantly the proximal LED is occluded. So similar clear-cut case as on the clinical presentation and on the ECG, and no surprise actually in the cath. And we did what we normally do, what I think everyone in this room does. We put a wire through, dilate, put stent in, and afterwards there was a little problem distal to the first stent, and the patient received 3 drug-eluting stents. Afterwards, there was a fairly good result, nice flow, and that is where we normally actually end our procedure. But the question is, what can we do? Can we do something more? And we should keep in mind that is a fairly young patient. She has a large anterolateral acute myocardial infarction. The echo, this image was taken when the patient came on the table, had already impaired left ventricular ejection fraction, and certainly from the history, she had prolonged ischemia. So 3 factors that are well known to contribute to a significant reperfusion injury. And the question is, what is the risk for this individual patient for recurrent myocardial infarction, for developing heart failure, or for cardiovascular death? And that's a question that I hand over to my following speakers.
Yeah. Okay, so thank you, Andreas, for this case presentation. Before we hand over to the next steps, I would like to introduce her, to hand over to Suzanne de Waha, and she is speaking about the role of infarct size and microvascular obstruction in STEMI patients and consecutive outcomes.
Okay, hi everybody. I'm super excited to be back in Paris, and I guess we all feel the same. But my task for right now is to give a short overview of the role of infarct size and microvascular obstruction in STEMI outcomes. So as Felix Mahfoud nicely pointed out, there's a lot of work for us to do with respect to prognosis after ST elevation MI. Notably, this is true despite the fact that we achieve a TIMI flow of 3, thereby meaning optimal epicardial reperfusion in more than 90% of all patients. So epicardial reperfusion is non-equivalent to myocardial reperfusion or tissue perfusion. So how can we measure real reperfusion success? One non-invasive option is cardiac magnetic resonance imaging. Using late gadolinium enhancement imaging, we can directly visualize and quantify infarct size and microvascular obstruction. We can assess it with low inter and low intra-observer variability. This is an example from a canine model. On the left side, you can see the cardiac magnetic resonance images. You can see these white zones. It refers to the hyper-enhanced infarcted area. Why is it hyper-enhanced? Because the contrast medium gadolinium persists in the ischemic myocytes, whereas it is rapidly washed out. It persists in the ischemic myocytes, whereas it is rapidly washed out in the viable myocytes. So this gives us this hyper-enhancement. And you can see that the CMR images directly correspond to histology. So CMR can truly be understood as an in vivo histology. There's unequivocal evidence that infarct size is an independent predictor for adverse clinical outcome. Recently, Gregg performed a patient-level analysis, including data from 10 randomized clinical trials, leading up to more than 2,500 patients. And as you can see here, he observed a strong graded relationship between infarct size and all-cause mortality or heart failure hospitalization. You can see that patients with small infarcts have a really good prognosis, whereas the risk for adverse clinical outcome is more than 7-fold increased in patients with large infarcts. In multivariable analysis adjusting for multiple clinical and angiographic parameters, infarct size was identified as an independent predictor for clinical outcome. Every 5% increase in infarct size contributed to a 20% increase in the hazard for all-cause mortality or hospitalization for heart failure within 1 year after primary PCI for STEMI. You can see another late gadolinium enhancement image. Again, you can see the white hyper-enhanced infarcted area, and within this infarcted area, you see this hypo-enhancement. This refers to the zone of microvascular obstruction. And there's absolutely no gadolinium, absolutely no contrast medium entering this core of the infarct due to complete obstruction of the microvasculature. So microvascular obstruction, or MVO, refers to the CMR tomographic equivalent of the angiographic no reflow phenomenon. However, it is much more frequent that an impaired TIMI flow, as MVO is present in almost 2/3 of all patients. And notably, the vast majority, more than 85% of MVO patients display MVO despite optimal epicardial reperfusion. So what is the prognostic impact of microvascular obstruction? Again, we performed a patient-level analysis, including individual patient data from 7 randomized controlled trials, leading up to more than 1,500 patients. And as you can see here, similarly to infarct size, we observed a strong graded relationship, strong graded response between the extent of MVO and the occurrence of death or heart failure hospitalization. The risk for adverse outcome was more than 2-fold increased in patients with large zones of microvascular obstruction. Again, microvascular obstruction is a strong independent predictor for adverse clinical outcome. It gives us incremental prognostic value over traditional clinical and angiographic parameters. And every 1% increase in microvascular obstruction has been shown to contribute to an 11% increase in hazard for all-cause mortality or hospitalization for heart failure. Finally, we observed that microvascular obstruction and infarct size are only moderately correlated with an R of 0.65. This is due to the fact that we see some patients displaying large infarcts without MVO or only small zones of MVO. And on the other hand, we see patients with small infarcts that mainly constitute of microvascular obstruction. So based on this observation, we performed this analysis where we grouped the patients according to microvascular obstruction and infarct size. And similarly to the other graphs I previously showed you, we could observe a strong graded relationship. So both MVO as well as infarct size should be the target of our therapy. So now let me conclude. Infarct size and microvascular obstruction can be visualized and quantified by CMR. Infarct size and microvascular obstruction directly refer to reperfusion success. Infarct size and MVO are both strong independent predictors for adverse clinical outcome after STEMI, and interventions reducing infarct size and microvascular obstruction appear to improve prognosis after STEMI. Thank you for your attention. I'm really happy to take questions.
Thank you very much indeed. Are there any questions in the audience? If not, we have one from Vladimir Chicho, and he's asking for your algorithm, Sissy. In patients where you see TIMI3 flow but persistent ST elevations, is that a patient where you would consider a microvascular obstruction? And how would you diagnose that patient? How would you treat it?
Definitely, yeah. A patient with persistent ST elevation is definitely microvascular obstruction, impaired with perfusion success, and that's also a surrogate for microvascular obstruction.
And is that a patient where you would consider CMR, or would that be sufficient to diagnose that patient with microvascular obstruction?
I would consider CMR in all patients after ST elevation MI.
Okay. Good. Any further questions here? No? Then let's continue.
Okay, so I think we should go on. Thank you. And now it's a pleasure to introduce Dr. Gregg Stone, who is hopefully remotely connected. Oh yeah, we see him. And he's talking about SuperSaturated Oxygen Therapy. Is localized oxygen the answer in left anterior descending STEMI in addition to PCI?
Great. Thank you. Well, thank you for giving me this opportunity. And I miss all my friends in Paris. I think this is the first EuroPCR in 25 years that I've missed. And hopefully that will be rectified next year. But have a great Congress. And I will speak about supersaturated oxygen therapy. These are my disclosures. You saw this where infarct size is probably the strongest surrogate we have to a poor prognosis in terms of both death and heart failure hospitalization. And impressively, despite current primary PCI techniques, the median infarct size is still 18% of the left ventricular myocardial mass. And these patients have a high event rate, even within 1 year, even if they present without cardiogenic shock. This is data that actually gets to that questioner's last issue, that even, this is from Horizons AMI, and even though we're very good by core lab analysis at restoring TIMI3 flow, 86% of the time, in about only half of the patients do we actually restore normal myocardial perfusion, as evaluated by myocardial blush and then ST segment resolution. So you could argue that about half of the primary PCI cases were actually being either suboptimally effective or ineffective. And so we shouldn't congratulate ourselves too much and think we're getting 90% success rates where it's really closer to 50%. And a lot of this is caused by microvascular obstruction, where you can't appreciate this usually angiographically because you have normal epicardial flow, but there's just no blood flow getting in to the microcirculation. So supersaturated oxygen was developed to as a therapy initially delivered through a tracker or other infusion catheter directly into the wounded left anterior descending artery myocardium after a stent was implanted, and to decrease microvascular obstruction and infarct size. So this was the first iteration of the device. And the way this works is by multiple different mechanisms. But the first thing that it does is by the local oxygen, the blood is infused from the patient's own femoral artery. It's withdrawn. It's then sent to a mixing chamber, and then it's hyperoxygenated to 760 to 1,000 millimeters of mercury. So 10 to 15 times the usual partial pressure of oxygen. It's basically bubbling out oxygen. And then once the LAD is opened, it's infused into the LAD territory. And what that does is it causes coronary vasodilatation. It reduces endothelial cell swelling. It actually reduces oxygen toxicity. And I'll show you a slide on that. And it improves regional blood flow. It reduces reperfusion injury and apoptosis. I could spend a half an hour talking about the mechanisms, but this experimental study showing that after you give supersaturated oxygen after opening an artery, the non-SSO2 treated artery has decreased blood flow where the blood flow continues to increase in the SSO2 treated artery. And a lot of this is because of decreased endothelial cell swelling. Endothelial cell blebs that develop in the infarct vessel constrict the lumen and actually decrease capillary lumen flow. And the endothelial swelling is totally resolved by supersaturated oxygen. And as I mentioned, there's concerns about oxygen therapy, because of ARDS in the lungs. But when you give it locally into the myocardium, it has the opposite effect. It actually reduces oxygen free radical mediated injury. And this is data showing reduced myeloperoxidase generation, an inflammatory marker of oxidative stress and free radical generation once you give SSO2. So it's actually interfering with the processes that cause reperfusion injury. The bottom line is that in experimental arteries, after 60 minutes of balloon occlusion in a pig, here's a large transmural infarct, and then you give, after reperfusion, supersaturated oxygen, and it essentially reverses the damage, or it doesn't allow it to go on to occur. And the nice thing is this does not increase door to balloon time because you're giving it after the artery is open. It's basically like putting a patient in a hyperbaric oxygen chamber to treat wounds or burns. It forces the oxygen into the damaged tissue and promotes healing. So we did a randomized trial, the pivotal approval trial for this in the United States called the AMIHOT-2 trial. I won't go into the details, but in general, 382 randomized patients. And you could see there was a reduction in infarct size from a median of 25% of the left ventricle. These are all proximal and mid LADs, occlusions, down to 18.5% with supersaturated oxygen. A 6.5% reduction, which is equivalent, had we enrolled several thousand non-shock patients, to about a 23 to 25% reduction in 6 month to 1 year mortality. We now have improved the technique. So instead of using a tracker catheter going right into the LAD, it's actually, the supersaturated oxygen is actually infused into the origin of the left main coronary artery through a simple diagnostic catheter. And so it actually infuses both the circ and the LAD, can cause some vasodilatation in the circ, can actually help with collateral flow from the circ if necessary, but otherwise has the same effect. And we did a safety study for this new technique called the ICHOT study. The MACE rates were very, very low. In fact, at 30 days, there was only one target lesion failure, just a few minor bleeds. And when we did at least a propensity adjusted analysis to compare these 100 patients to a similar non-SSO treated population from the INFUSE AMI trial with anterior infarcts, you can see that death or heart failure hospitalization at 1 year occurred in 12% of non-SSO2 treated patients. And in this small study, 0% of SSO2 treated patients. So this is not a randomized trial, but it's certainly suggestive that the reduction in infarct size may lead to improved clinical outcomes. So in summary, primary PCI restores epicardial TIMI3 flow in about 90% of patients and reduces infarct size compared to fibrinolytic therapy, the mechanism through which it improves survival. But nonetheless, despite successful primary PCI, myocardial salvage is frequently suboptimal, resulting in large infarctions with adverse LV remodeling, heart failure, and death. Supersaturated oxygen is the first and to the date the only FDA-approved device-based therapy shown to safely reduce infarct size in a pivotal randomized trial. Thank you very much.
Okay, so thank you. Impressive data. Are there any questions in the audience?
Please identify yourself. Yeah, hello.
Oh, hi. I'm Asif Khan, one of the cardiology consultants from United Kingdom. So just one quick question. The way we use a lot of microvascular, circulation drugs, if you have a slow reflow or TIMI2 flow, is there any plans or looking into using supersaturated oxygen versus these drugs to see if we can try? Because I think naturally this device not going to come into market or practice that easily, but we currently have all those drugs we use like adenosine or nitrates, So is there any study going, or you have any more data on that?
Well, I can tell you those drugs have largely been proven ineffective in reducing infarct size and improving prognosis to the extent that I just showed you. For example, there have been pretty elegant studies showing that both adenosine and nitroprusside look like they increase coronary flow, but they're doing it by sending blood to the non-infarct zone. They actually don't directly reduce microvascular obstruction. So this is the first technique that's really been shown to do that. So I think they're perhaps complementary, but they're not competitive.
Gregg, thanks for joining us. A question related to potential patient populations that benefit most from this technology. Any clues from the data that you have available, specific patient characteristics indicative of response to this treatment?
Yeah, so great question. Right now we use it in patients presenting basically within 6 hours of anterior ST segment elevation MI with a TIMI 0 to 2 flow in the proximal to mid LAD. And the results are very consistent with TIMI 0 to 1 or TIMI 2 flow and with both proximal and LAD infarcts. The greatest benefits are going to be in those patients with severely depressed LV function at baseline. So if you were to do a baseline echo, this is pre-reperfusion, or a contrast angiogram pre-reperfusion, when the anterior wall is severely hypokinetic or akinetic, those patients are going to benefit tremendously. That's the one real predictor that we've identified so far. If, on the other hand, because of collaterals, for whatever other reason, the anterior wall is only mildly hypokinetic or even normal, despite the fact that there's anterior ST segment elevation MI, then from an absolute point of view, there's less benefit.
Perfect. Thank you. I think we should go on, and we have now the part 2 of the case presentation, and the patient had depressed LV function, and we're curious to see how it was going.
Yeah, what did we do in addition to primary PCI? So just to remind you again, it was a 48-year-old female with a large anterior lateral AMI with impaired LV ejection fraction. And the most important thing was the procedure was finished at 5:22 in the afternoon. That was the last image I showed you in the first part of this case review. And we quickly exchanged the femoral sheet to the 7 French sheet. The 7 French sheet is used to draw blood from the femoral artery via the side port while returning it from the Therox device over the 5 French catheter. So it's a single access technique. The catheter was placed rapidly since the procedure, as you saw from the beginning, as we had SSO2 in mind, was done femoral. We know very well which catheter would fit, and the therapy was started, and all this was done within 4 minutes. The therapy continues for 60 minutes, was completed and well tolerated by the patient. And just to give you an idea on how the setting in the cath lab looks like is a tutorial video that we made in a kind of a mock situation in the cath lab. It's basically we get one set with all lines and the cartridge connected. It's sterile. You hand over the cartridge to the cath lab nurse, connects it within the device. You connect the drawing line with the side port of the 7 French sheet, and the oxygenated blood is returned through the arterial line, which is connected with the catheter that is placed already to the left main. So easy of that. And just to remind you, the imaging after the PCI and SSO therapy on the left on the transthoracic echo, and then an echo done 4 days later, where you can see already some recovery in the wall motion and without regional wall abnormalities. On the bottom, again reminded, it is a large anterior MI, proximal occlusion of the LAD, and the patient had the chest pain for several hours, so prolonged ischemia. we saw a maximum creatinine kinase release at 12 hours of 710 units per liter. Now, the question could obviously be, what would have been the infarct size if we hadn't done it, if we just only do primary PCI? And you have already seen some MRI pictures to assess infarct size. We also use MRI to detect the area at risk, or to get a good idea of the area at risk. My MRI imaging and this MRI images for the edema show you that there was actually quite a large affection of the anterior wall, the interventricular septum, the apex, and the apical lateral wall. Now, we don't stop with MRI. Tobias, together with one of the colleagues from our nuclear medicine department at our institution, they have developed a nice imaging technique using the fibroblast-activated protein imaging with PET-CT, which seems to be the most appropriate marker to nicely and definitely find the area at risk retrospectively. In this image, you can see again, it's the interventricular septum is more or less completely brightly showing that there is activation there, indicating that this was relevantly occluded and endangered, again, plus the apex and the apical lateral wall. Now, the functional recovery, again, the MRI from day 4 nicely shows that there is no persistent regional wall abnormality with a good regained ventricular ejection fraction. Just to remember, the ejection fraction was significantly reduced in the beginning. Now, we have made several cases, 15 cases until now. From the first 11 cases, we have data from the MRI studies, and we can show that on average, these patients recovered to an average LV ejection fraction of about 50%. All patients with large anterior MIs, proximal occlusions. The area at risk determined by the MRI was on average 40% in these patients, and the final infarct size was reduced to 20%, so just at the median what was shown in the previous studies by Gregg. And further studies will actually focus on the 3 patients that more than the others profited from the therapy, trying to identify markers or predictors of good response to the therapy. You've seen this slide on microvascular obstruction by Suzanne de Waha, indicating that we should aim for less than 1.5% of the left ventricle having microvascular obstruction. And we were happy to see that the majority of our patients was below this threshold, with, again, the majority of them having almost no microvascular obstruction. The median was actually driven here by one severe outlier. So, in summary, myocardial reperfusion injury and microvascular obstruction are associated with increased rates of heart failure and death after primary PCI and STEMI. Supersaturated oxygen therapy is easy to apply following successful PCI, does not delay revascularization, does not require much larger access sheets as for primary PCI, was well tolerated in all our patients, and was rapidly accepted by the cath lab team as part of the standard procedure. And the image on the right-hand side is not when we did this teaching movie. This was done actually during the case number 14, which was a case that happened on call late in the evening at 11 p.m. And it was actually the cath lab nurse, when we came to the cath lab, who asked us whether we would go for supersaturated oxygen therapy, because she had heard that it was an anterior MI coming in. And with that, I thank you for your attention. I thank specifically our cath lab team for supporting us with this.
Thank you. Really impressive case. Are there any questions?
Thank you. Nice presentation. My question is technical. How do we use this? How do you use this technically?
Technically, as I said, it's a 7 French sheet that is placed into the most right femoral. If we do the cases that we intend for SSO2 therapy, having impaired LV ejection fraction, large anterior MI within the first 6 hours, we go femoral with a 6 French sheet in the beginning. Then we know the guiding catheter that fits well. And once we have we're about to finish the procedure. We're going for the last angios. We already start the machine. The machine is in the cath lab. We start it up. So it's ready to be used. And then we exchange the sheet, which is very easy, actually. And then we connect the drawing line, so if you call it the venous line, on the side port of the 7 French sheet. It goes to the machine. Blood is oxygenated, and the oxygenated blood comes back and is connected to a 5 French diagnostic or guiding catheter, which is a dedicated one that has been placed in the meantime.
And the patients remain in the cath lab for 60 minutes?
And the patient remains on the cath lab table for 60 minutes.
Okay.
It's not possible to do it from radial?
It might be possible to do it from radial. At the moment, there's one possibility is the femoral single access. The other option that momentarily is kind of allowed is to use a transradial for the guiding catheter and use a 4 or 5 French sheet for the drawing. You have to draw about 100 milliliters of blood per minute, which you at the moment can't do by a second transradial line, but there are investigations in the UK underway to assess whether a peripheral or more proximal second sheet in another artery can actually help you to do it by radial.
There's another question.
Thank you. So the
Can you
orthodoxy...
identify yourself, please?
Oh, sorry.
Can you identify
from
yourself?
the UK.
Hi.
Dr. Andreas. So the orthodoxy about reperfusion injury, the initial descriptions of it, is that it is potentiated by hyperbaric oxygen. So you get an increase in infarct size and dysrhythmia. That's reperfusion injury, not microvascular obstruction. They are related, though. And now we see these results where you give it in a different manner and you get really good results. So what are we doing here? Are we pushing out all the microvascular obstruction and getting a good benefit? Are we post-conditioning? What do you think is the process?
It's funny in the beginning, if you hear it, because over the last years, everyone was saying, no, not too much additive oxygen. The problem is that the additive oxygen that you apply via a nasal tube, mask, or whatever, is not going to give you as much plasma oxygen. It will be bound mostly to the hemoglobin. And what they could see in the initial experiments in the hyperbaric chambers, like 40 years back, was that doubling the external pressure increased the amount of free oxygen in the plasma by 14-fold. And what is believed is not that additive oxygen bound on the hemoglobin is preventing the microvascular problems, but the oxygen that is more or less free in the plasma, that can travel, go to the distal part of the coronary tree, where the erythrocytes that get stuck somewhere in the microvascular cannot go. And so this is the primary target, is the free oxygen in the plasma.
So it's the localized delivery that's making the difference.
Yeah.
Interesting.
Igor asked a question, Andreas, and it's related to the fact that he was interested whether or not you could use venous blood for that therapy. Why not drawing blood venously?
So, yeah, it's a good question. It's a question that we had in the beginning as well. What one wants to assure is that most of the hemoglobin is actually saturated with oxygen to begin with, and this is also the case. We are checking with a primary blood gas analysis. Even before we start primary PCI, we are checking the PO2, and if the PO2 is below 80, we already give some nasal application of oxygen to get the oxygen really normal, and then all the supplied oxygen from the SSO2 therapy actually goes into the massive increase of the plasmatic oxygen and is not kind of wasted on saturating up the hemoglobin. And the important thing is to really increase the amount of plasma oxygen.
So it's not possible at the moment?
It's not possible at the moment, no.
Yeah, Andreas, I would be interested in your clinical experience. What about the symptoms of the patients when they have a cath in the left main for 60 minutes? What is your experience?
Simple answer, most of them are sleeping. No, I haven't been doing such extensive taking of history of cardiovascular risk factors and all the stuff in patients. But in the first cases, we also thought we have to talk with 60 minutes with these patients. And like after 10 minutes, they say, oh, doctor, just let me sleep. They are free of the infarct pain and they just lay there. They are sometimes agitated in the beginning, but not due to the procedure, but due to the myocardial infarction. When they come on the table, they are revascularized. You know from the cath lab how patients behave once you have revascularized them. It's a completely different animal to what came into the cath lab with the infarction. And they answer your questions, but then in the end, they say, oh, I'm fine, I'm free of pain, I just want to sleep.
So I think we all understood that acute myocardial, anterior myocardial infarction and severely impaired left ventricular ejection fraction are those patients that may benefit most. But are there any contraindications where you would not use it? Relative and absolute contraindications.
So at the moment, we are aiming for the large anterior MIs. The reason for that is actually something we have seen in the trials with unloading, in the trials with medications, in the trials with hypothermia. I think there's a good sense about it. The ones where we can really improve ejection fraction are the patients with large anterior MIs within the first 6 hours. This is where we see the most benefit. And to the contraindications...
No, just one question. And you do an echo or you do an LV angiogram?
While the cath lab nurse is trying to cover the patient and prepare the exercise, we're doing a 2-3 image echo, which we do anyway to get an impression on ejection fraction as a part of screening, is the patient going into shock or not. And that is actually the second situation where we do not apply the therapy at the moment in the shock patients. There is something else that we have to clarify with clinical trials. If pre-shock or shock is a good, maybe even better patient population for that, but that's something that has to be clarified by a randomized control trial.
So shock would be a contraindication. Anything
At the moment,
else?
yes.
Anything else?
If always absolute contraindications, I would be concerned about leaving a patient who is hemodynamically unstable extensively longer on the cath lab table to extend it further if I'm very progressive in supporting patients in cardiogenic shock with mechanical circulatory support. If I have the patient on the table stabilized with hemodynamic circulatory support, it's not what we intend to do at the moment, but I don't think that the patient would be endangered by them applying this. But I think it has to be cleared in a trial.
Okay, so we're running out of time. One quick question and one quick answer. The last one from David from the chat. Do you need continuous anticoagulation during therapy? Very important question.
Yes, we do not need continuous by means of intravenous continuous infusion of heparin, but we are given additive boluses of unfractured heparin and we control the ACT. Yeah.
Okay, thank you. Okay, so let's wrap up very shortly. I think we've nicely shown that open the vessel is key, that's clear, but we can do more for our patients in order to reduce infarct size and microvascular obstructions and improve prognosis, but we still need more data, that's clear, and hopefully we get those in the future in order to prevent heart failure and to improve outcomes. And thank you for your attendance. Nee, das haben wir rausgenommen. So, just in case we skipped a very short talk on clinical perspective due to time.
There are clinical studies ongoing and registries. That was one slide only showing the ongoing trials. There's one study ongoing in the US, one other study planned in Germany. So more data to come. Stay tuned. If you're interested in the topic, scan the QR code here on the water bottle and you will receive more information. Thank you very much.
Thank you.